Welcome, and thank you all for joining us today in honor of National Eating Disorder Association's NEDAwareness Week 2016. This year, NEDAwareness Week's theme is 3 Minutes Can Save a Life. And this focuses on the importance of early intervention and prevention of eating disorders. Today, we're fortunate to be joined by 3 professionals who have vast experience in these areas, and they'll be sharing their insights as to the validity of these points and why it matters to us all. My name is Michael Levine, and I'm an emeritus professor of psychology at Kenyon College in Central Ohio. I'm also on the Founders Council of NEDA, and I'm excited to be moderating this discussion today. I'd like to take a few moments at the beginning here to have our panelists briefly introduce ourselves. I'll say the 3 names and then we'll go in order. Our 3 panelists today are Chevese Turner, Dr. Lesley Williams, and on behalf of the American Psychiatric Association, Dr. Angela Guarda. Chevese, will you take a moment or so and introduce yourself?
Yes, thank you, Michael. Hello, everyone. My name is Chevese Turner, and I am the founder and CEO of the Binge Eating Disorder Association. I am in recovery from binge eating disorder and very pleased to be here today.
Right. Dr. Williams?
Yes. Hello, everyone. My name is Dr. Lesley Williams. I am the co-founder and CEO of Liberation Center. I have worked in eating disorders for over 10 years, and I'm very excited to be talking about early intervention. It's a topic that's near and dear to my heart, so thanks for the invitation.
And Dr. Guarda?
Good afternoon. I'm Dr. Angela Guarda. I'm an associate professor of psychiatry at Johns Hopkins, and I'm the director of the program for eating disorders here, and I'm here representing the American Psychiatric Association today.
Thank you. Let's begin right away with talking about early intervention. It's well known that early intervention can make a significant difference, a significant change in the course of the development of an eating disorder. And I'd like to spend a little time talking about why that is and how that process works. So let's start with Dr. Williams. What exactly is early intervention, and why is this something important for people to know about?
Well, early intervention means that we are recognizing these disordered eating patterns before they get to the point where the person has a serious problem. So the idea is that we don't wait until it's a crisis. We want to intervene early on. So in order to do that, we really need to get the word out to the public at large, as well as to the medical community about certain signs and symptoms to look for so that we can identify these people early, get them help, and then ultimately they may not need some of these higher levels of care in terms of treatment because we were able to intervene at an earlier stage.
Dr. Guarda, what would you add to that?
I think early intervention is important not just in recognizing the beginning of a clinical eating disorder, but also in recognizing and addressing disordered eating itself, which is very common, if not normative, in our culture, especially amongst young women, but increasingly really amongst young men too. And there are many ways in which early intervention can be addressed, but certainly there are interventions like media literacy, understanding how the media portrays the thin ideal, for instance, understanding that dieting tends to be associated more with weight gain than with weight loss in adolescent females, and stigmatizing dieting in a sense is very important. Stigmatizing the fact that dieting is not generally successful, especially crash dieting. These are not effective ways of long-term losing weight and maintaining weight loss long-term, because the general consensus amongst adolescents is that dieting is a positive behavior and that it is something that they like to emulate in their peers.
Right. Chevese, based on your experience in recovery and also on your extensive advocacy work, how do you believe early intervention makes a difference in the lives of those who are struggling?
Well, at the end of the day, the earlier we can diagnose, recognize disordered eating and possibly the early stages of an eating disorder, the better the outcomes are going to be. Hopefully we can save people from progressing to a full-blown eating disorder. That would be the great hope. But secondarily, we want to make sure that when people are starting to present with these illnesses, that we can intervene early and save them and their families and our society, really, the angst and the trouble and what the body goes through physically in a full-blown eating disorder. And as an advocate and as someone who has struggled, my hope is that no one will have to go 30 years before they are before they realize that they have an eating disorder and things progress to the point of no return.
Thank you. One of the things that the field has been able to illuminate time and again is that no one is immune from an eating disorder, in that eating disorders affect people of all ages, males, females, people, different socioeconomic status, different ethnicities and such. As I said, no one is immune. That said, we know that some people have been excluded from the conversation and from the research. That is, there are those who are marginalized. And Dr. Williams, how do you think early intervention makes a difference or could make a difference in including more people in the conversation around eating disorders and also in getting treatment to more people who need it?
Well, I think when I think of early intervention, I think about education. And although we've made a lot of progress in the eating disorder field, an area where we really haven't progressed is moving beyond that very kind of unilateral view of what an eating disorder patient looks like. Still, in the community at large, they think of a young, adolescent, thin, Caucasian female. That's the image that immediately comes to people's minds whenever you say eating disorders. And now that we've really even expanded to include binge eating disorder within our repertoire of eating disorder diagnoses, that view of a eating disorder patient really needs to expand. So I think that the more we educate people, let them know the signs and the symptoms of an eating disorder, and really start getting people comfortable with coming forward and saying, you know what, I am engaging in some of these behaviors. And when we get away from that stigma such that people, regardless of what they look like, feel comfortable saying, hey, I'm struggling, then I think we can start to change the public's view of what an eating disorder is. More and more people are going to be identified, and more people are going to get help. And so that's, you know, an area that I feel really passionate about in terms of eating disorder advocacy, is really getting the word out and kind of changing that very narrow view of what an eating disorder is and what an eating disorder patient looks like.
Thank you. Chevese, in your work, have you encountered this kind of marginalization, and have you seen it affect people who are suffering from binge eating disorder or who may be suffering, and their willingness to seek help and so forth?
Absolutely, and it continues. It goes on. We have a lot of work to do just within our this demographic of binge eating disorder. Only 17% of people with binge eating disorder have been diagnosed, and of those, only 7% are getting any kind of treatment. So we're talking about millions and millions of people who are still marginalized, who believe that obesity may be their primary problem. They don't fit the mold that Dr. Williams just spoke about, and so they are greatly overlooked. I have the privilege of being a white woman with a platform for BED, but the greatest numbers of people with BED are people of color and some other, I would say, not only marginalized but oppressed groups. So it has affected us greatly, including around the issue of weight stigma even within the eating disorders community.
Thank you. Dr. Guarda, as a medical professional, not only treating eating disorders, but also educating students and families and people in the community, how do you see the impact of marginalization on this issue?
I think the impact in the medical community is very significant for some of the reasons that Dr. Williams alluded to, and especially outside of eating disorder experts, general practice physicians, and gastroenterologists, OBGYNs. Many medical specialties see patients with eating disorders, but they often don't recognize them, and that's especially true when they don't fit the typical mold. So older patients, male patients, and racial minorities may not be recognized. And one thing to notice about eating disorders is that there's a significant stigma attached to eating disorders like other psychiatric conditions. Plus, in some cases, patients are somewhat ambivalent about seeking treatment. They kind of want help, but not 100% because they're scared that treatment is uncomfortable. And they may not present saying, I need help with an eating disorder. So especially when they don't look like a typical patient with anorexia, say a young white girl, they may go unrecognized. And unfortunately, this can result in significant long-term complications, both medical complications, psychological consequences of a serious eating disorder, and sometimes social or functional impairment.
Okay, thank you. Speaking of that kind of impairment, Chevese, I've heard you talk at length, and other people have been fortunate to hear you talk about how having an eating disorder affected you on multiple levels. Can you say a little bit about your experiences and, in particular, how the impact on daily life may be apparent to people in ways that can motivate them to reach out and say something? To reach out and say, I'm worried about you, I'm seeing this and this and this, let's talk.
Yeah, I think we all in the professional and advocacy world realize that eating disorders are disorders of solitude, and so the effect of isolating yourself from the world is a big sign that there is something going on. In my own situation, for years and years and years, the focus was on the weight and the size of my body being the problem, and not recognizing that there was an underlying disorder going on, and some major depression that was really fueling something that needed to be attended to. So this affected every single aspect of my life. I share the story sometimes that when I was filling out college applications and it came time to fill in the hobbies section, the only thing I could think of at the time that I was good at and really was a hobby was dieting. And so I made things up for my college applications. That's I look back now and think about how sad that is. But that was my life. I was all consumed with my eating disorder. I wasn't able to move forward and successfully complete college my first couple tries. You know, marriage came later for me. There were a lot of things that were on hold while I really focused on the things that I thought were wrong with me, without having the mental health aspects really attended to. So life with an eating disorder is isolating, and it is something that stunts one's life until you can find true help and treatment.
Chevese, before I move on to Dr. Williams, can you tell me, in retrospect, I'm sure you've thought about this, in retrospect, what would you have liked those around you, whether it's family or friends or college professors, what would you have liked them to said to you, or or what did they say to you that turned out to be helpful under the circumstances?
Well, unfortunately, with what you know, the lay public knew, and my family and the physicians and the people around me knew at that time, there really was not a lot that was very hopeful that was said to me. It was sort of a pull yourself up by your bootstraps suggestion that was pretty common. I think that now, with more information, that what I would have liked to have heard from my family and others was, you know, can you describe to me what's going on with you, and what can I do to help you find out what resources are out there for you? I think some empathy and some help in looking past, you know, what was appearing on the outside, and really beginning to look for a specialty area that may be able to assist.
Dr. Williams, what do you see in your work and in your reading and such as some of the significantly altered parts of people's lives when they're struggling with an eating disorder?
Well, I see that it impacts all aspects of their life. And the sad part is that oftentimes, kind of like what Chevese talked about, people have lived with this for so long, when they come to see me, they can't even really describe what life is like without it. So it's hard for them to imagine a happy, healthy life where they're able to achieve all of these goals that they anticipated for themselves. They really get to this point where that's difficult for them. So that's usually where I start in an assessment, is kind of like, where would you like to see your life and how can we help you get there? But that's the one thing. It impacts their interpersonal relationships. It impacts their ability to concentrate and focus at work. It oftentimes impacts them physically in a lot of ways. They have a lot of physical symptoms, and typically that is the one thing that will bring them to my office, is that the physical symptoms have gotten so significant that they're really ready to make a change because they are so uncomfortable. And so that might be where we start, but then we start to kind of peel back the layers and see all of the different ways that it's impacting them beyond that physical symptom that might bring them to me at this moment.
Okay, thank you. Dr. Guarda, can you pick up on that and tell us a little more about the medical effects and how those not only play on themselves and interact with themselves, but also affect the individual's friendships, the individual's ability to participate in activities they want to be participating in, whether it's sports or academics or clubs, groups, church. Mm-hmm. Can you elaborate on some of those effects?
Yeah, well, when you think about the medical complications of eating disorders, they're consequences of the behavior. So they can be consequences of restricting and starvation, consequences of binging, consequences of purging by vomiting or using laxatives or diuretics. And the reality is that the medical complications of eating disorders affect every organ system in the body, and in severe cases are life-threatening. So certainly I can't cover them all, but just to give you some examples of things we worry about, a common consequence of using laxatives or purging or restricting fluid intake is dehydration. And dehydration causes symptoms of feeling dizzy, of passing out, of poor concentration. So they can affect your schoolwork, your ability to pay attention, which is important often to to young people and students who often have eating disorders. But the more serious complications tend to be the long-term consequences of a sustained eating disorder, and certainly of severe restriction or purging. And they can include electrolyte abnormalities that can be life-threatening, bone loss and osteoporosis, cardiac complications, and GI problems. And the GI consequences of eating disorders are very significant. Both upper GI consequences of vomiting or binging, and lower GI consequences, including constipation with starvation and problems related to laxative abuse. So the reality is that these medical complications tend to interfere with function because they literally make you feel sick. And therefore, and they also affect, eating disorders affect social eating. And often patients are uncomfortable eating in social settings. They start to avoid eating meals with other people, eating the same food that other people eat. So gradually, the eating disorder comes to interfere with many spheres, not just physical complications, but your social relationships with people around you. You become more and more concerned and may ask more questions, and that may lead to avoidance and really a breakdown in relationships.
So that's the type of withdrawal hardly does it justice. That's the type of retreat, withdrawal, isolation that Chevese was talking about.
That's correct.
In some ways, you literally don't feel like interacting with other people. You literally don't have the energy or don't have the physical, emotional, social, psychological wherewithal to do much but push yourself through what absolutely needs to be done.
Mm-hmm.
Absolutely.
That's been your experience as well, Dr. Williams?
Absolutely. It definitely, eating disorders become an issue of isolation where your world becomes so narrow, and it's difficult to even see your way out of that because you've just cut out so many different aspects of your life. And so that is a huge part. And, you know, as we were speaking previously about early intervention and things to look for, isolation is definitely one of those hallmarks, and it can also make it difficult for people to seek help when they've become so isolative, when they've become so kind of retreated into their own life. And so that's why the more we get the word out and the more that people are aware and can kind of draw people in and give them some hope, hey, why don't you go talk to someone and maybe get some help, it's a better way to reach the public at large.
Let me develop that a little more. I often hear typically older people say young people these days don't care as much as we used to. Teachers these days don't care. We even hear physicians don't care as much. Everybody's so busy. Everybody's so wrapped up in their own struggles and tribulations. It's been my personal experience as an educator and as a professor and someone who talks at campuses and such that in fact most people care a great deal.
Mm-hmm.
They just don't know what to do. And my experience with students, I'm not sure if it's true of medical students or trainees, is that they not only don't know exactly what to do, they're terrified of doing the wrong thing, saying the wrong thing. They're terrified of making a mistake that only makes matters worse. So I wonder if each of you, and let's start with Chevese, if each of you could say a little bit about how you help people break through that. What are some practical steps to reaching out to somebody whom at some level in your gut, your heart, your own eyes, you know is hurting?
Mm-hmm.
And you might think it's an eating disorder, you might not be sure, but you know that this person is struggling. Chevese, what do you do in helping people break through that, well, I wanted to say something but, or I wanted to do something but,
Right.
situation?
Right. Well, I think that, you know, I look at my eating disorder as a gift in some ways. And for that reason, when I reach out to people or people come and ask me, I have the ability or I have the privilege of hindsight. And so I can share what I know, you know, with regard to my own struggles and how I would want to be reached out to now. I think the biggest thing for me when talking to family members and so forth is to let them know that they don't have to fix this themselves. They just need to be compassionate and begin to look into what eating disorders are all about. Go to the various websites. NEDA has terrific toolboxes. BEDA has information that we have developed and are in the process of developing, and get some advice from people who have been there. Talk to other people, call NEDA, call BEDA, call some of the other organizations, and talk to them about what it is that the person that you're concerned about does and doesn't want to hear. We have to be ready for that to be met in all kinds of different ways. We need to meet that person where they are, and at that point, it may not be a place where they want to take in that compassion and listening. They may not want to talk. And so we have to plant the seeds. We just need them to know that we are here and that there are many, many, many other people out there that are struggling, and give them some sort of hope alongside that compassion.
Thank you. Dr. Guarda, how do you approach this in working with family members and working with physicians in training and working with community members who, as I said, maybe I have a skewed experience, but my experience is that people want to help and that they know something is wrong, and they're often very challenged by their own anxieties or by just not knowing what to do.
I think if I was to say two things, I'd say one is very important to instill hope that everyone can change, everyone can recover from an eating disorder. That's kind of the first thing, and what I mean by that is many patients, and this was alluded to earlier, come to believe that this is a chronic part of them, and don't believe, they describe themselves sometimes as a lifer. There's no such thing as a lifer. Everybody is capable of recovery, but seeking treatment has got to be the first step. And the other thing I would say that is the most important take-home point is don't be silent. Speak up. Because as Chevese said, you may be met by denial, by minimization. Someone with an eating disorder may try to not want to talk about it, but the more they hear from a supportive, empathic person, I'm worried about you, I think you have a problem, this is why, this is what I'm seeing you do, the more likely they will get to the point that they're ready to engage in treatment. And I think this applies to family members. It's the more you tell your loved one you're worried and why, the more likely they are to engage in treatment. And it applies to practitioners, to health practitioners, even health practitioners in different fields. I just went to my dentist last week, and I said to them, do you see patients with enamel erosion from vomiting? And they said, all the time. And I said, well, what do you say to them? And they said, nothing. And that's an important point. We need to educate other medical professionals that when they pick up signs of an eating disorder, they should say something to their patients, supportively, empathically, but say, you know, there is treatment and treatment works. The reality is we have treatment for these conditions. Maybe not everyone responds the first time, but nearly everyone gets better with treatment, and many make full recovery. So it's very important for those two things to happen, to instill hope and to talk about it.
Thank you. Dr. Wynn, your thoughts on this really important matter of getting across to people who need help and may be ambivalent about help? How do you approach this in your own work and in your educating others?
Well, I think in terms of educating others, I think that people recognize that eating disorders are very complex, and they're often afraid to bring up the topic because they genuinely don't know what to do. Like, what if the person does admit that they have an eating disorder? Like, I don't know what steps to take next. So I loved what was said earlier about educating people that there are resources, there are treatment options, and once you kind of open that door to have that discussion, then you can refer people on to get the help that they need. It's not that you yourself have to solve that problem, and I think that's part of the reason why oftentimes people don't want to bring up the subject, is because they genuinely don't know, what do I do next? I think in terms of family members and friends reaching out, one of the things that I find is that they often don't say anything until there is such a physical change in that person, and they're very focused on the physical appearance versus kind of what you've seen going on with them emotionally, whether it's isolation or being more depressed, and so I find that when you come from that position of, you know, I've noticed a change in you and your emotions, you're not as happy, and just kind of planting that seed that other people see that you're struggling, and even if right now you're not prepared to talk about it, you've opened the door for discussion in the future. I think that that can go a long way, because people are at all different stages in their willingness to get help, but ultimately, as things progress, they will remember, hey, you know, that friend had mentioned that they noted I was struggling. Maybe that's a safe person that I can go back to and kind of let them in a little bit in terms of what's going on with me.
Thank you. If I may, a moment to summarize, what I'm hearing you say is in effect saying to the person directly, I'm concerned about you. Then saying to the person, as Dr. Guarda said, I have seen or felt the following things, and maybe list 3 or 4 things that have come to your attention. And then saying to the person, talk to me, tell me what's going on with you, tell me what's happening right now, how are you doing, what are you struggling with? And then the 4th step that you just mentioned, Dr. Williams, is not arguing, not making this into a battle. If you know in your heart something is the matter and the person is saying, no, everything's fine, you can say, I think, I hear what you're saying, that's not what I'm saying and not how I feel. If you change your mind or the door is open, come talk to me, rather than saying, what's the matter with you? You must be so ill you can't even see there's something wrong with you. Is that, those 4 steps sound like a legitimate way of approaching this to each of you?
Absolutely. And instilling in them that there's hope that you can get help and that you can feel better.
Yeah, and there's something we can do together
Mm-hmm.
to investigate resources, to go to a doctor's office together, to do something that, you're not alone in this. I may not know exactly what's going on with you. In fact, it's not up to me to render some kind of diagnosis. It's up to a professional to do that. But we can approach this problem together, and there are resources that you and I together can marshal.
Absolutely.
Let's extend that a little bit. Dr. Williams, in work that you do with parents or with professionals, what are some of the misconceptions or even mistakes that you've encountered that people make when other people are showing signs of an eating disorder or other people are in need of help? What are some of the pitfalls that hopefully we can avoid?
I think some of the big pitfalls that I see is there's a desire to focus on oftentimes the medical associated issues or the physical complaints, and so they may spend tons and tons of time and money doing extensive, you know, GI workups or other kind of workups, just hoping that there's some type of medical reason for some of the symptoms that are going on. And it's not until a lot of time and a lot of resources have been spent that someone introduces the idea that maybe we should look at it from a different perspective. I think, again, going back to that idea of early intervention, is that whenever someone is dealing with complex issues, it makes sense to be able to talk to someone who can see that from a more holistic standpoint earlier on in the process, not after, you know, kind of $1 million workup and everything in the world has been explored. And I think that that would also take a load off of oftentimes the patients, because once they start down that road and the whole family and friends and everyone gets invested in kind of finding that one thing that's causing all of their symptoms, it's a lot more difficult to explore the idea that maybe there's an underlying eating disorder that we need to look at.
Okay. Dr. Guarda, can you humor me a moment? Let's assume that you had complete control over medical and nursing education and such at the Johns Hopkins. People who will be working in emergency rooms, people working in OBGYN, people working in endocrinology. Assuming you had complete control over that kind of medical education, what are some of the basic messages that you would want to get across to people through education, but also through practice, in terms of detecting and reaching out to and referring people who are suffering from an eating disorder?
Well, I think it would be important to make sure that physicians understand what an eating disorder is and what the signs are, what questions to ask of patients. But you know, I think that one of the reasons that these disorders don't get recognized by physicians and health care practitioners is that they ask one question and then they give up. So there are simple things that help, simple history-taking questions that help. There are screening tools that are helpful. Certainly the screening tool that's on the NEDA website right now already is a way in to help someone think about, who may be in some level of denial or embarrassed about their eating disorder and not seek help them think about doing so. But I think medical professionals are very busy. They often know what something like anorexia or binge eating disorder is in a way, but they don't really know what to ask. So they may ask, do you have anorexia? That's not a very good question. Most patients will say no, even when they obviously do sometimes. But if you ask things in a different way, like what is the most you would be comfortable weighing, or tell me what you ate yesterday exactly, you may be able to understand better whether their routine fits with the disorder. Are they eating fat-free? How much are they exercising? How much would they exercise if exercise did not burn calories? These are the kinds of questions that clinicians don't always ask, that often may be helpful in making a diagnosis. Or with binging, you know, asking do you binge is not a very good question to elicit a binge eating disorder. It's much better if you say, do you ever feel like you've lost control over your eating? Do you ever feel like you eat large amounts of food, more than most people would under the same circumstances, and feel very negatively about it? So this, I think, these are some of the things that it would be important to educate health practitioners to do a better job of. But the other problem is that they give up too easily. You know, they need to ask, look for collateral informants. A lot of times you get a much better picture if you don't speak just to the patient, but speak to their family. Families are very important allies, both in the detection of and in the treatment of eating disorders. We routinely ask all new evaluations to come to our clinic with a family member, not just because we want to involve the family in treatment. We always want to do that, but because oftentimes the parents have seen something and they may be able to help us understand, get a fuller picture of what the problem is and how to address it.
Thank you. Chevese, how do you feel that non-medical professionals or non-professionals in psychology or social work, how can those type of non-professionals get involved in raising awareness about eating disorders and becoming more, promoting greater awareness about the signs and symptoms and how people can reach out and start this process of referral and effective treatment?
It is going to take an entire community. It's going to take a village. Activists, those who have had eating disorders, family members, anyone who has a story to tell really has so much power to save people from lengthy terms of an eating disorder. By telling your story and explaining, you know, what your symptoms were, how it presented, the help you got, and so forth is just essential. And whether that's coaches or family, like I said, or the individual, there's a plethora of people out there who have all interacted with someone with an eating disorder, and just being able to share that within their own social circles, not you know, who the person is necessarily, but just telling the story and how critical it is for people to understand what the symptoms are and so forth. The other thing that really concerns me is, and we talked a little bit about marginalized voices, you know, and this is for non-professionals and professionals. We really need to be talking about this in a way that makes it very clear that the the color of their skin, the size of their body, you know, whether they live in the United States or not, who they love, whether they're gay, bisexual, lesbian, straight, you know, whatever their gender is, however they gender identify. There's so many people out there that the things that we're talking about today are actually things that are nowhere close to interacting with someone who would ever think about asking those questions, because the understanding is not there that there are so many people struggling that are not within the group of people that are interacting with others who have eating disorders. So within the, you know, the white upper middle class, you know, parents of girls and so forth, I hear a lot of talk about eating disorders. But when I go into other areas, when I go to churches where people of color pray, and I've been invited to speak at several churches, they, you know, this is the first time they've heard any of this. And so we really, really need to focus on spreading the word that this affects everyone. This is not just a white middle-class girl's disorder, as Dr. Williams stated at the beginning.
Thank you. We have a couple of minutes left according to my timekeeping. Dr. Williams, is there anything that you came prepared to talk about this afternoon that I haven't asked you or hasn't been brought up, or you feel it needs to be emphasized again and again and again?
Well, I would just like to piggyback on what Chevese was just saying. I think that we've talked a lot about early intervention and we've mentioned these marginalized communities, but I would like to talk about specific strategies to target these communities so that we can get the word out that eating disorders are heterogeneous and there are just people of all different size, shapes, and shades that suffer. And the more that we're able to reach that community and get the word out, the more those people are going to feel comfortable seeking help. And so I think churches, as Chevese mentioned, is an awesome opportunity. I've also had the privilege of speaking at my alma mater, Spelman College, which is a historically black college and university, and I was able to talk to them about eating disorders, and so many of the girls identified with those behaviors but had never put a label on it, such as an eating disorder. And so that was a great opportunity. I think that college campuses are awesome opportunities, community centers. You know, there's lots of community centers, even in our community in Phoenix, that focus on the LGBTQ community, but they don't speak specifically about eating disorders. So being able to use that as a platform to talk about eating disorders within that community, which I am personally seeing in my practice more and more. So I think we know that it's a problem, and now, you know, being able to really strategize how can we get out there and target all of these millions of people that don't even recognize what an eating disorder is and how it's impacting them so that they can get the help that they need.
Thank you. Dr. Guarda, I'm going to give you the last word here. We have about 45, 50 seconds.
Well, I want to echo what everyone else has said, that the importance of recognizing eating disorders amongst a wide range of people, not just the more stereotypically thought of populations. I also want to recognize what Chevese said about binge eating disorder being a newly included category in the DSM-5. But to mention something that hasn't been mentioned yet, and that is this other category of eating disorders labeled ARFID in Diagnostic and Statistical Manual, which is avoidant restrictive food intake disorder. This includes individuals with picky eating, individuals who lose weight for reasons other than concern for body shape and weight and that are not medically explained. And these individuals, too, respond to behavioral modalities of treatment that apply to eating disorders. But it's important that even if you have something that doesn't fit anorexia, bulimia, or binge eating, help may be available for that, too. And I just wanted to mention that because we haven't really talked about RFID, but RFID, we don't know what its prevalence is, but we see a significant proportion of patients with this condition who do very well with treatment. So there's hope for all of these conditions. And my last word would just be, if you think you may have a problem with eating, even if you don't think it's really a clinical eating disorder yet, talk about it and ask for help.
Thank you. This brings us to the end of our Hangout this afternoon. I want to thank each of our wonderful panelists for sharing their insights about this set of important topics. To learn more about early intervention and ways that you can get involved in NEDA's Eating Disorders Awareness Week, please visit NEDAwareness, NEDAwareness.org. Thank you.
Thank you.
Thank you.